We've seen the human toll of the shrinking support for TB programs. But what happens when the fight itself changes? When the very bacteria we are trying to defeat learns to resist our best weapons? One missed dose, one broken system, that's all it takes for the disease to fight back, stronger and deadlier than before. Joseph Gikundi in Torebe sits quietly at the edge of his world, his thoughts trailing into the horizon where the hills fold into silence. Here, in Meru, at the heart of rural Kenya, he opens a window into a fight that is both deeply personal and profoundly global. His legs could no longer carry his weight, his frame shrunk, and a violent cough tore through the silence of the nights.
Wakati nilikuwa nikishikwa na hiyo ugonjwa, nilikuwa natoa jasho mingi, kwa kitanda inakuwa maji. Nikienda nachoka hapa. Sasa ndio ni kazini mwingine yangu akaenda akaitwa na hiyo mkazini mwingine, nilikuwa nalala kushinda pale, nilikuwa nalala. Akaniambia lazima tuende hospitali. Tukaenda Kadidi. Daktari wa Murioki wakanituma huko General. Hapo ndio ilijulikana niko na TB. Wakati nilipimia, jua alikuwa anasikia vyenye nilikuwa nakoa, kukaa kwa jua, nilikuwa natetemeka. Wakati waliniona tu daktari walianza kusema huyo mtu sasa ameanza kupona. Tuliwa tunaona huyu anaenda. Niliambiwa hiyo ugonjwa imeingia mpaka kwa mifupa. Sasa nitumie hiyo dawa mpaka ishe. Na hiyo dawa nilikuwa nakunywa kwa huyo abasi. Nilikuwa naenda mbio. Juu zingine zilikuwa na usingizi. Sana nilikuwa nakunywa na kimbia mbio. Hata wakati mwingine nilikuwa nalala njaa, niliwekelea tajiona asubuhi. Wakati nilianzia kukunywa hiyo dawa, nilikuwa nasikia mbaya tu, lakini mpaka hata miguu kukua mburaki yote. Na huko mikono. Mwili yote ilikuwa na mandoa. Hata daktari mwenyewe aliona hiyo maneno. Aliniambia nikimalizia dawa ni hivyo.
A quiet guardian of discipline and care, a community health promoter walked beside him, ensuring that every pill was swallowed, every dose accounted for.
Mwanzo vile alikuwa ako very weak. Alikuwa hawezi hata kutembea. Ndio sababu ilifanya mimi niambiwe niwe namwendea dawa. Manake alikuwa very weak na kila wakati alikuwa anachoka, kutembea ilikuwa ngumu sana kwake. Kuna siku alikuwa kama Sundays alikuwa anakuja akiwa mlevi. Sasa hizo siku nilikuwa napigia daktari simu, akaniambia kama amekunywa asikunywe dawa hiyo siku. Sasa ilikuwa inatubindi tuongeze siku mbele ndio tulikave zile siku ambazo alikuwa hajakunywa.
But Joseph's story isn't his alone. Philip, the community health promoter, had told me the truth about this place.
Kulingana na vile najua, na watu wale nimeona wako na TB ni wengi, zaidi ya 10. Tulikuwa tumeambiwa tukiwa huko tunapeleka monthly report ya kwamba North Imenti Mkongorone area iko number 3 in North Imenti. Na hiyo ilifanya watu wale wanandio na medical wao harati sana na wakao concerned. Sasa ndio ilibindi wafanyiwe medical camp hapa, ndio waende wachukumwe huko. Walikuwa ndani mazinani, walikuwa wanaenda wanatolewa na chief na assistant chief, ndio waletwa kwa rasima pale kupimwa. Na walipimiwa, wengi walipimiwa na walipatikana na TB.
Here in Imenti North, coughs linger behind closed doors and silence hides the suffering.
Watu huku wanaamini TB ni ugonjwa ambao hata uko naibu kutaja. Maanake ilikuwa inasemekana hapo zamani ati mtu akisikwa na TB anakuwa mwembamba mpaka anaambiwa anakula nylon. Sasa hiyo ndio kitu ile inafanya watu wafiche huo ugonjwa wa TB. Maanake hata mtu akijua ako na TB hawezi hata kukohoa akiwa mbele ya watu, anaenda kujificha, anaenda kukohoa akiwa kando, ndio watu wasijua na TB.
For Joseph, this was not his first encounter with TB. Once before, he had turned away from treatment as he feared being seen or judged. So the disease lay in wait, gathering strength, shaping itself into something more dangerous.
Wakati hiyo ugonjwa ulinishika, nilikuwa Isiolo, nikakuja huku hata nikashindwa kurudi, nikaanza kusikia mwili mbaya, kuanza kulalala hapo, hata naletwa chakula inashindwa kukula.
Here in Meru, the air is clean, but the burden of TB is heavy, including the kind that doesn't respond to standard treatment.
Here, the fight against TB is not just clinical, but cultural. To understand the scale of the problem, I met with the county's TB coordinator.
Meru County is rated among the high TB burdened counties in the country, the top 10. Actually, I can say the top 3. When we look at the drug-resistant TB, still we are not behind, still among the top, 5 counties reporting the numbers. 2023, we reported around 79. 2024, there was a drop. We reported 57 cases. This year, as at today, I think we've so far reported around 50 DRTB patients. You can see that by the end of the year still we expect to get maybe to around the 70 or even above. The bad hit sub-counties are Imenti South, Imenti North. You also have the Egembe South. Those are the top 3. They have been doing that over the years. And then followed now by the Egembe North and the Egembe Central. So those 5 sub-counties are actually giving us almost 70% of the TB cases that we are reporting within the county. Patients are not coming to us in time because they are associating TB with the HIV so much that once you start wasting, coughing, and there are so many changes in your body, you start not thinking HIV and you really not ready to get to the hospital. So they come when they are very sick. So those are some of the things that are fueling the disease.
In Meru, TB is a shadow that isolates and silences voices.
When it comes to TB, silence is dangerous. Every missed dose, every delayed diagnosis gives TB a chance to evolve.
And this is how ordinary TB evolves into its most ruthless form, multi-drug resistant TB.
The drugs that we use for TB management are 4 RHZE, that is rifampicin, pyrazinamide, ethambutol, and isoniazid. There are 4. They have to work together because every drug has an area where it attacks. So the resistance comes in when you expose to small doses, maybe regular dosages, and then the bacteria wears the coat, the antibiotics are not able to penetrate. So that one is one of the factors that are fueling drug-resistant TB. And then, if these patients infect others, they will go down with a drug-resistant TB.
We shall always ensure you are manipulating the sample while inside the biosafety cabinet, not outside.
In the fight against TB, speed saves lives. With just a small sample, new molecular tests like GeneXpert can uncover the disease in hours and even expose when it is drug resistant.
Our GeneXpert equipment is able to diagnose one of the drugs, rifampicin, one of the TB drugs, rifampicin. It will be able to diagnose if the patient has got a multi-drug resistant TB due to rifampicin. If you check at my modules, you can see 3 modules are color blue coded. These 3 modules can also be able to diagnose other drugs like isoniazid, ethambutol resistance. But for microscopy, you only tell these are bacteria and it's there. But for gene expert, it will tell you there is a bacteria in that specimen, and that bacteria is either drug sensitive or it is drug resistant.
AI-powered chest X-rays now act as a second set of eyes that can diagnose TB with remarkable accuracy. In villages and towns, even with scarce resources, this speed brings a new kind of power, the chance to begin treatment early, to save lives and to stop resistance before it takes root. But the machine, the labs, and the skilled hands behind them are all powered by a single fragile current, donor funding. And when that stream dries, progress is threatened.
The diagnostics actually is fully donor funded. Commodities, some of the equipments, they are donor funded. We also have the community strategy facilitations when they are doing the home-based care, the tracing, still it's donor funded. When we come to drug-resistant TB, the monthly workups, these patients are taking very toxic drugs, so we do monthly biochemistry or follow-up of their samples. So that one is done, it has to be paid through Lancet, it's still donor funded. Like recently we want some activities cancelled, like capacity building, told this one has now since been stopped. We've also had the healthcare workers and Jamii Tekelezi. So I think from September they are not getting support anymore. So those ones will move out, and mainly their care was the TB HIV patient. So the counties will now have to employ or even recruit more so that at least they can fill in the gaps. The other one is sample networking. Actually, sample networking has been partner supported all through. So if another strategy is not brought earliest possible, I think that one will really make us go back to where we started.
For patients like Joseph Gikundi, these aren't just budget lines, they are lifelines. In Meru, I saw the insidious creep of drug resistance, quiet as a shadow. I wonder what will happen when that shadow finds fertile ground in the very heartbeat of a nation. Here, life picks up pace, and the close-knit community of a village is replaced by a vast, interconnected web of millions. The same hidden enemy lurking in the air and amplified by the rhythm of a city that never stops. Kenya is categorized as one of 30 high TB burdened countries globally. In 2024, we uncovered around 750 cases of drug-resistant TB, harder to treat, slower to heal, and far more dangerous if left unchecked.
We have made significant problems. However, I have to report TB is now again the #1 single biggest infectious killer in the world. During the time for the COVID pandemic, of course, COVID overtook TB, but the numbers of deaths due to COVID have diminished. Unfortunately, during that time for COVID, since most of the focus was on the COVID-19, containing the COVID-19 pandemic, then TB efforts took a back seat, and TB has actually been thriving those few years after the COVID pandemic. And from 2022, the numbers were higher than previously. The trend before the COVID pandemic was the TB numbers were declining year on year. The TB deaths were declining year on year. But after the COVID pandemic, for the first time, we actually had an uptick. So the number of cases were higher than the previous years. And of course, that moves along again with mortality, because the more people have TB, about 10% of TB patients will die.
Here in Nairobi, the disease won't just creep. It will pulse and spread with every shared breath. In 2024, Nairobi recorded 14,000 TB cases, each one a story caught in time, but an estimated 40% of infections slipped past the system.
We did another prevalence survey, but this was not a national one like 2016. We did it in Nairobi in 2022. We went back where we had gone in 2016 to just see what is the change, what is the evolution from 2016 to 2022. And for Nairobi, we found that TB is still high. It is persistently high. So as much as the government has put in a lot of interventions as concerning getting the missing cases, we then informed them there are more issues, because even the data showed us we have socioeconomic issues, we have social determinants, which we got from our study, which we need to also consider. The main difference we saw on the socioeconomic part was unemployment. Unemployment is very high compared to 2016, and there could be so many factors related to it. There are some areas we noticed increased housing. There are a lot of high rises which were not there in 2016, and that may have contributed to this. And then the nature of the houses, poor ventilation, poor lighting.
In 2023, the National Leprosy and TB Program uncovered cracks in the system. Hospitals ran out of testing cartridges, fragile referral chains broken, and drug-resistant TB slipped past unnoticed. With 15% of Kenya's entire TB burden living here, the unseen shadow of drug resistance would become an urban storm. Research may be our invisible shield against TB, especially drug-resistant TB. It gives us the data, the tools, and the foresight to act before crisis strikes.
I may not have all the results of our recent national anti-TB drug resistance survey, but it's complete. And in this survey, we were trying to assess among the people who come with confirmed TB, the new patients. We had new patients and people who have had TB previously. We want to find out from them. All of them were having their specimens tested for drug-resistant TB by gene expert and by culture. And also, we are doing a cohort of them, we are doing some genome sequencing. So as of now, we have results for the gene expert and the culture. This time, we are doing genome sequencing to understand exactly the patterns. And we are doing drug resistance on first line, second line, so that we know exactly the drug-resistant patterns at different levels. There is research we would want to do, and the funding has gone down. So we have to think beyond the normal funders, but we also want probably within the country, domestic funding to support us. They have been supporting us, but it's gone down. It has thoroughly gone down. I don't think they've given us much this current financial year. So we would wish that could be considered. I don't know how, but probably we can give suggestions. So when funding goes down, clinical trials go down, some progressing work stops, and it affects. And then we are put in a situation where is the future research going to be? Yeah, and there is effort put in developing these protocols, and sometimes it's quite demotivating, but we don't want to give up.
It is an effective COVID vaccine that was able to almost eliminate COVID in that short time. And it happened because there was a lot of investment in research and development. If we do not invest in R&D, again, we shall be mark-timing in the same place that we have been mark-timing for the past many decades, because we urgently need a new vaccine, like we urgently need a vaccine, that may be the magic bullet that may finally lead us into ending TB by 2030.
Our country breathes a heavy collective breath. Progress is fragile and the enemy is relentless. But with greater care and stronger investment, even the smallest lungs can be protected. Their story is the breath we must listen to now.